there is 2 others of me.
That's still
Yeah, but you can hear me fine.
Hello and happy Monday, everyone, and happy NMO Awareness Month. My name is Sumaira, and I'm a patient living with seronegative neuromyelitis optica spectrum disorder. I was diagnosed in 2014, and 2 months after my diagnosis, I started the Sumaira Foundation, which is now an international nonprofit organization dedicated to raising awareness of NMOSD, MOGAD, and other rare neuroimmune conditions. We're very passionate about building communities of support for patients and their caregivers. We support research and fellowships, and of course, advocate on behalf of patients. We're very proud to be patient-led, patient-powered, science-driven, and therapy agnostic. And to us, diversity is still a superpower. This webinar today is nothing short of a dream come true. Since I started doing work in advocacy for our rare diseases, I have always wanted to work with the doctors in sub-Saharan Africa, get to know the patients of sub-Saharan Africa, help build community, help, bring better diagnostics and treatments and whatnot. So this webinar just marks the very beginning of what I hope the foundation is able to do in collaboration with all of the doctors and patients and caregivers in sub-Saharan Africa. Before I turn it over to my colleague Letitia, I do just want to say that the foundation calls a number of patients and caregivers ambassadors from countries in Africa. So we have Letitia from South Africa, who you will meet shortly. We have Trudy from Africa. We have Rokaya, who is from Senegal, living in Canada. We have Lois, who is from Ghana, living in Scotland. We have Rosalind, who lives in the UK, but is from Kenya originally. And we also have some ambassadors from the Northern Africa region, from Tunisia and Algeria. So we remain dedicated, and this is just the beginning, as I said, to the entire continent of Africa. But I hope that today's presentation helps shine a light on the landscape of rare neuroimmune conditions in certain countries in the region. And please do not feel shy. If you have questions, we will have a dedicated section to questions. And in the meantime, I would love to ask everyone to enter into the chat where you are dialing in from, just so we can see where everyone is coming from. And on that note, I pass it off to Letitia Anamale.
Sure. Thank you so much, Sumaira. Good evening, everyone. Thank you so much for joining us. I'm just really excited about tonight. I've been looking forward to this webinar since it was actually announced. My name is Letitia, as Sumaira has said. I am a 27-year-old living with NMOSD in Johannesburg, South Africa. I was diagnosed officially in 2018, and I was then in 2020 named the first international ambassador of the Sumaira Foundation, which is definitely a title that I, take a lot of pride in. I've recently been promoted to the International Ambassador Liaison, working with so many amazing people from all over the world, so many amazing patients, clinicians, and other advocates. So thank you so much for joining us this evening. I'm really excited. I see everyone popping in where they're logging in from. Hi, Martin from Cape Town. I see people in Joburg. So thank you so much for taking out the time to be here today. And I'm really looking forward to, all of the amazing things that are going to come off this webinar. I would like to introduce Dr. Fiifi Duodu from Kolebu Teaching Hospital in Ghana, who's going to kick off the webinar for us, please.
Hello.
Hi, we can hear you.
Good. I'm trying to share my screen.
Uh-oh, let's see. Oh, we could see it.
Okay. So thank you very much for this wonderful opportunity. It's a great pleasure to share knowledge with the rest of our colleagues from sub-Saharan Africa to get educated and know what's happening on the continent. she said, my name is Dr. Fiifi Duodu, general neurologist working in Kolebo Teaching Hospital, and then with a special interest in demyelinating diseases. And so today marks a day for us to talk about NMO in sub-Saharan. I'll kickstart about the NMO perspective or the NMO picture in Ghana. So this will be my outline. It starts from the prevalence and incidence we have, the process and timeline in diagnosis of NMO, and some challenges that we have, available therapies that we have for both acute and then the preventive ones, and if the vaccines or possible immunizations, and the support groups that we have here in Ghana. It's like we know that, in fact, when it comes to NMO, the epidemiological studies are a little bit scarce. However, most conducted studies are in the white population and Caucasians. And you know that population-based studies would makes us aware that the whites have lower prevalence of NMO compared to MS. And as it moves from the Asians to Blacks, the prevalence sort of increases. And so for Blacks, it's been estimated as 10 per 100,000 populations, compared to whites, so that's approximately about 1 per 100,000 populations too as well. However, all the data that we have in Ghana currently are estimated data because we don't have any population-based study here. The prevalence, like we know for NMO, unlike its comparator MS, is quite more female predominant, 9:1, and then the median age about 40. However, this age sort of, the average age reduces in Blacks and in Asians, and it's been seen that the Blacks range from about 28 to 33. So this is the world map showing population-based study of NMO. You can see a lot of them have been done, and not much in Africa, and then in sub-Saharan Africa too as well. So this is a map taken out from the Multiple Sclerosis International, an article that actually shows the prevalence of estimated prevalence worldwide globally. And you can see Ghana, that light blue color of a prevalence about 0 to 1.4. And actually in that paper, I actually estimated that at that time, in 2015, there were 30 people living with NMO at the time. And that put out a prevalence about estimated of about 0.12. And also the mean age at the time was about 30 compared to the 40 that we do know. Compared to MS, for this an MSIS, Multiple Sclerosis International Federation website, the prevalence is compared to the prevalence of MS is relatively high in Ghana compared to that of NMO. And this puts out a prevalence of about 1. And this at the time was taken, we had about 152 patients living with MS. But today we'll be talking about NMO in Ghana. And so I was privileged to be awarded the pre-grants from MSIF, and my mentor and host was Professor Diana Sela. And so we undertook taking a registry of both MS and NMO. So this is from the NMO registry. In total, we had 21 patients living with NMO, and there was predominantly females, about 8:2, which is quite similar to what we know out there, about 9:1. The average age from the 21 was about 32 years, and actually ranging from about 20 to 60 years of age. So the initial symptoms they talked about at the time, majority of them had optic neuritis from the 21 patients, which is quite similar to what is known out there. And then the second most common one was transverse myelitis or paraparesis, followed by other sensory symptoms and other non-specific symptoms too as well. So from the time when a patient had their first symptoms to when the diagnosis is being made, on an average, they had seen 2 subspecialists before the diagnosis were made. Majority of them were general practitioners, and majority of them saw general practitioners. Some also, in fact, the second most common was neurologists, followed by ophthalmologists and neurosurgeons too as well. The average time from symptom onset to diagnosis was about 21 months, and then the average estimated disability scores, or the EDSS score, was about 5. That's approximately, most of them were walking without aid for about 200 meters, but they had severe disability, severe enough to impair their daily activity. So in terms of investigations, from first symptom onset, like we saw, either from the first time they had the optic neuritis or PAP or the transverse myelitis, to when they had an MRI done, took them about, on an average, about 11 months. In fact, 59%, close to 60% of them had positive serology tests of positive alpha-4 antibody tested, which was positive. The rest was deemed as the seronegatives. Investigations are available, I must say, in Ghana, but it's a cash and carry system, so it's pay out of pocket. And so the patient will have to pay all these things from their pocket. An MRI or the lumbar puncture, OCT, and then the serum NMO antibodies. For the serum NMO antibodies, we currently have the cell base, which is the live one, and it costs about $140. For patients who have had fully investigated from MRIs, whether even for the spinal cord, for the brain, lumbar puncture, doing serology on the NMO, suspected NMO, and ruling out other possible causes of this debilitating CNS or demyelinating disease. With the patient initially would have spent a roughly an estimate of about $500. We do have therapies and do have the acute as well as the preventative therapies. IV methylprednisolone is available. We at the point we just had the original one was quite expensive, and it cost the patient about close to about $50 to $100 to complete the 5-day course of the IV methylprednisolone. We rarely do plasmapheresis. However, based on plasmapheresis that we do on people with myasthenia gravis and then GBS, an average 70-kilogram patient will cost about $3,500 to $4,000. And like I said, most patients are not able to afford, and if after we fill IV methylprednisolone or patients don't respond, we want to switch to plasmapheresis, but most often than not, the patients are not able to afford this amount. So for the 21 patients, almost all the patients were on some sort of therapy. Some I must say were on 2 or 3, a mixture of maybe a steroids here and a steroid sparing here, or had just been switched to rituximab and so about 81% of them were on prednisolone, that's steroids. About 53% of them mainly were on azathioprine, just a few was on mycophenolate mofetil, and 33% of them were actually on a disease-modifying therapy, which was rituximab. And this is because most patients can't afford rituximab. For the 2-gram course, which they might be taking every 6 monthly, the total cost was about $1,300. And so most patients were able to afford. Most of them were put on azathioprine because it was relatively cheaper, and for a month course, it could cost about $5. And so that's what most of them are on. The other known approved drugs are not available in Ghana currently. However, there are some clinical trials, but not necessarily for NMO, where they are using satralizumab. So it's available, but not available to the patients. And this is the CELIO trial for autoimmune encephalitis done in the northern parts of the country. And so these drugs are, though there's satralizumab in the country, it's for a clinical trial and not available for our NMO patients. Before the patients actually start, of course, the patient will have a thorough workup before they start on the disease-modifying therapy. We now have a anti-TB prophylaxis for about 3 months, which they take weekly for 3 months. Patients on other like hepatitis B viruses are placed on tenofovir, irrespective of their viral load, because we know they're going to be on immunosuppressants. Now, moving forward, the way forward. We currently have a WhatsApp group, but I must say it's mainly active for those who have multiple sclerosis. The NMO, I must say, is a little bit difficult because most of them have optic neuritis unless they use their family members to assess. So we normally do a call-to-call basis and run a clinic for them. So there's no like a support sort of group like the multiple sclerosis, which is well established. We are currently in talks with Roche, and Roche have a rituximab, and so they have a payments plan, and this is spread over the whole year for them. Currently, that's what Roche is doing for them, so that we can actually increase our number of patients from 33% to hopefully 100% being on disease-modifying therapy when they do need them. And so Roche spreads these treatment, the pay as you go or monthly payment, and so it's not too much on the patient. Again with Roche, we are actually having some talks with the government. We have a new president who's actually established what we call the Mahama Care, where we want to actually have a discussion with them and see if our patients could actually be on rituximab for free or on the health insurance scheme, because it's hopefully due to some of the MSIF project, it's now on the essential drug list, and so this is what we are currently pushing for. I might say that this study was really successful, or this registry that we set up was really successful. First of all, to my patients who are always willing to partake in this study, despite the countless number of questions, we're really willing to, and they are quite hopeful that maybe we'll have some clinical trials, or there will be some hope along the line where their burden will be relieved. I also thank Prof. Diana Sila, who was a mentor and my host. In fact, she was the first patient who made mentor who made me aware that I need to look into MS and NMO. And then to my surprise, it's quite huge here in Ghana. We have close to about 75 in total, both MS and NMO combined. And then also a big thank you to MSI for giving the Dupree Grant Award. Majority of this study was actually the data collection and calling of patients, setting up the WhatsApp groups, were mainly done by my students who are medical students, and they are very enthusiastic in helping out and always calling to check up on these patients. So this is in summary, a simple story, or the Ghanaian story about NMO. In summary, just about 21 patients. Most of them are not on medication, are not on disease-modifying therapy, which is the rituximab that's available. And also it takes them quite about 21 months to make a diagnosis, or 11 months to have their first MRI done. And this is purely because of cost. Going forward, we hope to put these things, cost on the insurance, and to make their life much easier. Thank you.
Thank you so much. Thank you so much, Dr. Fiifi, for outlining, all of this important information for us in relation to Ghana. Thank you so much for the slides that you've presented, and I hope that everyone in the room today took some important information away from your presentation. I just want to give a heads up to everyone in the room with us today. In terms of the questions and answers, we are going to allocate the last 30 minutes of the session just to go through the questions that you guys might have. In the meantime, if you could just drop your questions down in the chat box for me, then that will be easier for me to go through at the end, and then we can direct the questions to the relevant doctors. But now we're going to move on to Dr. Pearl Thomas, and she is joining us from the Tygerberg Academic Hospital in South Africa.
Hi, good evening, everyone. I just quickly want to share my screen. Just give me a second. Screen. Hi, can everyone see my slides?
Yes, we can. We can see them.
Okay, I think it might not be in presenter mode, but I will just click through. Thank you so much for the Sumaira Foundation for inviting me tonight to this platform to share our experience with NMO. I just wanted to give an overview of my talk. So I will be talking a little bit about Tygerberg Hospital and where we're situated in Parra Valley. I will be looking at the data on the epidemiology of NMOSD in South Africa. And then I thought just to give an idea of the patient journey through our system. And finally, just to close off with a few comments about clinical research in NMO in South Africa. Can I just check, is everyone seeing the slide with Tygerberg Hospital on it?
We currently on this slide that says overview, Dr. Thomas,
Okay.
and it's not in slideshow mode on our end.
Yes, it's just on a different screen. So I will just carry on with these slides for now. Okay, so I work at Tygerberg Hospital, and that is an academic hospital associated with Stellenbosch University in the Western Cape. I'm a general neurologist, but I do have an interest in autoimmune neurology. And I thought for reference, I just show you a picture here of someone famous from Parra Valley, and that is one of the Springbok rugby players, Eben Etzebeth. So South Africa is quite a complex, or has quite a complex healthcare system. And I think it would be useful for us maybe just to take a few moments to consider the system before we could go into deeper detail about the epidemiology and the patient's journey through the system. So we have about 147 neurologists, of which about roughly 30% are based in the public healthcare service. We have a two-tiered system so that there's a public and private sector. The state provides healthcare to about 84% of the population, and currently at our last census in 2023, we were 63 million people, while the private sector only serves about 16% of the population. So you can see here in this infographic on the side that the breakdown is that 15% of the population is serviced by medical schemes, whereas there's 18% that are medically uninsured, but they are employed. There is a 12% group of patients that have informal employment and are considered uninsured. And then there's this large group of 55% of people that are uninsured, are unemployed, and basically rely on the state healthcare service for healthcare. So we have 9 provinces, and these provinces then are distributed as you see in this graphic. So the Western Cape, Gauteng, and KwaZulu-Natal are probably the most populous areas, as you can see on this next slide. But you will see that they are also fairly small provinces, and that the bigger provinces of the Northern Cape, the Eastern Cape, which are the historically less better resourced areas, are also the geographically larger regions. We can also see that in this picture that the population density in South Africa is concentrated then in the urban centers in the Western Cape, KwaZulu-Natal, and Gauteng, with the Eastern Cape then being more sparsely populated, the Northern Cape being very sparsely populated, and patients having to travel quite long distances if they are ill to access care in the Western Cape, the Free State, or even Gauteng if they reside in the Northern Cape. So next, I would like to chat just about the epidemiology of NMOSD in our country. Maybe I would just give the context that, in the private sector, if a patient develops a neurological syndrome, their ability to access a neurologist and directed testing would obviously depend on where they reside. So that we have provinces such as the Gauteng and Western Cape and KwaZulu-Natal that are very well resourced. These provinces have several private hospitals with access to advanced diagnostic modalities such as MRI and laboratory testing. So let's perhaps take a step back and look at the epidemiology of NMO. And so in this figure, as reported by the previous speaker, we can see that in this study published in 2018, that there were no cohorts from the African continent. And similarly, in systematic reviews of epidemiological data from 2020 and 2023, there is a paucity or complete absence of information from Africa. But what we have been able to deduce from these data is that indeed the highest incidence and prevalence of NMOSD is in populations with predominantly African ethnicity, with an incidence at 0.7 per 100,000 person years and a prevalence at about 10 per 100,000 people respectively. So just for context, the Western Cape, Gauteng, and KwaZulu-Natal are the most populous provinces in South Africa. Our total population is 63 million, but it is anticipated then that we should be seeing the highest burden of these cases in Gauteng, KwaZulu-Natal, and the Western Cape. Now, specifically at our experience in South Africa, unfortunately, the epidemiology in South Africa is largely unknown. There are several reasons for this. The first is that both in the private and the public sector, hospital and practitioner information systems are separate and fragmented across institutions. Testing for the aquaporin 4 and MOG antibodies only became available in South Africa around 2014, but there are clear geographic limitations to accessing laboratory testing as well as MRI imaging. In many provinces, assessment is still directed by general practitioners, referring to doctors without specialist training or general physicians. Barriers to accessing healthcare is another reason why the true incidence and prevalence of NMOSD is unknown. Patients living in urban centers have easier access to hospitals, whereas patients in rural areas experience several gender, economic, and geographic barriers to accessing care. Across the board, an overburdened state sector and unaffordable care in the private sector may restrict patients accessing care. I would like to show you some more locally collected data to get a better impression of our local epidemiology. At Tygerberg Hospital, we are in the process of setting up a digital database of our cases, so I can't unfortunately give you a good idea of our local cases, but we have in the past observed the association of NMOSD with intercurrent tuberculosis. And here are two examples of studies that have been published on this topic in the past, 2011 and then most recently in 2014. At Groote Schuur Hospital, which is based at the other medical school in our province in Cape Town, an audit was performed in 2023 by one of their neurology trainees and now consultant, Dr. Goulet. The primary objective of this audit was to retrospectively identify and characterize the clinical presentations of cases diagnosed with NMOSD presenting to the Groote Schuur Division of Neurology between 1 January 2013 and 31 December 2019. So I'd just like to walk you through this infographic that gives you the methodology of how this was approached. So broadly, on the one side, Dr. Goulet had cast a net out by looking at the laboratory system in terms of all the sera that had been tested for aquaporin 4. And so 1,703 sera was submitted, but only 105 tested positive. Of those 105 cases, there was a total of 35 cases that were from the Groote Schuur Hospital referral facilities. Of those cases, then there were cases that were attending Groote Schuur Neurology, and that amounted to 52 patients, but it was then clear after going through the case records and eliminating duplicates that there were only 44 cases really that were seropositive and met diagnostic criteria. Of these possible NMO cases, there were 9 that then were considered negative because they did not meet the 2015 International Panel for NMOSD diagnosis criteria, whereas only 35 were then considered positive. And then in the breakdown of those positive cases, remembering that these were all the cases that attended Groote Schuur Hospital, or were tested in the periphery, 17 were positive and 18 were tested seronegative. It's not clear from this data whether these patients were also tested for MOG, but it should be kept in mind that MOG testing only became available around 2017, 2018. So what is quite striking is thus that there were 35 diagnostic criteria and testing confirmed cases or verified cases over this 7-year period. And strikingly, the rate of seronegativity was far higher than reported in the literature. Although one may argue that this data may simply be a sampling artifact, I think many of my colleagues would agree that this may be a representation of the fact that we may observe more cases of para-infectious NMOSD in South Africa. South Africa has a high burden of infectious disease, especially tuberculosis, HIV, and syphilis. And these infectious diseases may promote the emergence of NMOSD, both as a promoter of disimmunity, as with HIV, or as an environmental trigger in the case of tuberculosis. Although we do observe an association between NMOSD and autoimmune disease, most strongly with lupus, our patients are predominantly younger and we hardly ever screen for malignancies. From Johannesburg, we have this cohort of prevalent and incident cases of NMOSD observed over the period of January 2023 to February 2024. As both incident and prevalent cases were included in this observation period, unfortunately, we cannot interpret this as a prospective cohort. However, it does allow us to appreciate certain cohort characteristics, such as that, again, it is borne out that these patients were predominantly female, that they were all of Black African ethnicity. And quite interesting, in this cohort, they found an aquaporin 4 positivity rate of about 89.7%. On the next slide, we can see that the predominant clinical phenotype that was encountered still remained a longitudinally extensive transverse myelitis associated with optic neuritis. Another interesting observation in South Africa is that the prevalent cases of NMOSD probably outnumber the prevalent cases of MS in South Africa, although this is something that has, again, not been systematically studied. But there are reasons for this marked difference, and this has to do with the racial disparity that we see in our country. MS has the highest incidence in the white, Indian, and mixed race or colored populations, whereas NMO has a predilection for Black Africans. Again, there is also the asymmetric burden of infectious disease among Black Africans in South Africa, so that environmental determinants, there are environmental determinants influencing this phenomenon and not only genetics. I would next like to go through the diagnostic odyssey of a patient with symptoms and signs of NMO in the South African system. If the patient resides in an urban center in one of the well-resourced provinces, such as in Cape Town, the Cape Metropole, in Durban, or in central Johannesburg, they are sure to be able to receive an excellent standard of care with fast-track access to a hospital-based neurologist, whether in the public or the private sector, and access to diagnostic testing such as MRI and serological testing for both aquaporin 4 and MOG antibodies with fixed cell-based assays. Universally, the Euroimmune kit is used in South Africa. Most private hospitals will have access to an on-site scanner in the urban centers, and the average is that there are about 2.5 to 5 MRI scanners in South Africa per million people. In the Western Cape, we have access to 3 MRI scanners in the state sector, and this does make it quite troublesome when we need to get urgent scans. Once seen by a neurologist, imaging in the form of MRI and chest X-ray is obtained, and this is because we have obviously observed para-infectious NMO associated with tuberculosis. The antibodies are tested for, and most patients will be reflexively tested for lupus and to a lesser extent Sjogren's disease, but the primary antibodies will include aquaporin 4 and MOG via cell-based assays. Most patients will undergo cerebral spinal fluid analysis to rule out alternative diagnoses, which in our setting may include infectious diseases like zoster myelopathy and tuberculous meningomyeloradiculopathy with cord edema. Furthermore, we also look for the oligoclonal band status of the patient on CSF. Most patients presenting to the state sector will also be reflexively tested for HIV and syphilis, while in private, this is done based on clinical suspicion. For acute treatment, we have access to intravenous methylprednisolone and therapeutic plasma exchange, both in the state and private sectors. Most patients who do not respond meaningfully to the methylprednisolone challenge are subjected to plasma exchange, and we offer 5 sessions on alternate days, and there is universal access for state patients to this modality. As is the trend overseas, we treat all patients who are aquaporin 4 positive with a prolonged course of steroids, which are tapered slowly while a steroid-sparing agent is introduced. We use in our hospital azathioprine as a first line, mycophenolate mofetil as a second line, and rituximab as a third line. And again, there is universal access for all patients in the state sector but this does depend on the patient accessing the care through failure on the first and second line agents. In the private sector, tocilizumab may also be used, but it is cost prohibitive in our state sector, so we don't use it at all. For patients wishing to conceive, we would use azathioprine as the agent of choice while using the lowest effective dose of corticosteroid. For patients who are MOG antibody positive, we treat with a prolonged course of oral corticosteroids over 3 to 6 months with a tail-end taper. Patients who have relapsing MOGAD are started on a steroid-sparing agent. The practice of treating double seronegative NMOSD varies across institutions and neurologists in South Africa. At our hospital, we treat the first attack with acute treatments, but do not offer ongoing immunotherapy unless the patient has a relapse. In the state sector, when patients have para-infectious NMOSD, this often entails us doing an extensive investigation for relapsing infectious disease when the patient has a relapse. This is particularly challenging in the setting of tuberculosis, as we currently lack biomarkers with excellent sensitivity and specificity to help guide clinicians in decision-making. We do not routinely vaccinate patients when treating them with azathioprine or MMF, but when subjecting patients to treatment with rituximab, they are vaccinated with both influenza and polyvalent pneumococcal vaccines prior to induction. We do routinely test all patients for hepatitis B surface antibody and antigen, and we immunize patients that are not immunized as well and offer them treatment if they indeed do have hepatitis B. There are currently no trials active. This slide just shows the Section 21 drugs. We don't use these specific monoclonal antibodies in South Africa, but they are available to us on Section 21, which is a regulatory process to import medications that are not available or manufactured locally. In terms of the clinical research in NMOSD, unfortunately, South Africa has very limited health and clinical research expenditure. So there are currently no trials active in SA with regards to NMOSD, but in the past, South African sites have been part of multi-site trials to test the novel monoclonal antibodies. As South Africa spends less than 1% of its GDP on clinical research, it is unlikely that the status quo will change, as we have a number of disease burden priorities, including infectious disease and non-communicable disease like diabetes and cardiovascular disease. Most of the research activities in the domain of HIV/AIDS, for instance, has historically been dependent on the US's PEPFAR funding, which has recently been withdrawn. I would envisage that the future of clinical research in the domain of NMOSD has to take the first step of creating a central database to capture data of the prevalence and incidence of cases, as well as the clinical characteristics. Many hospitals are moving towards digital record keeping, which may allow for better data capturing and collaboration across centers in South Africa. Obviously, once we have collected this data, it will inform us about the epidemiology, the disease characteristics and associations and treatment outcomes in South Africa. Because we have such well-developed digital databases for laboratory test results and radiology results, it would be possible to cross-reference these databases to a disease clinical information database. It will also then allow the unification of fragmented hospital and practitioner information systems. And this is an innovation that will require not only, or this is a step that will require innovation, as it will not be possible for South African clinicians to take on the additional work. So we may have to rely on novel techniques such as AI. Furthermore, I also think it's important that we consider biobanking samples, especially for this large cohort of double negative neuromyelitis optica disease that we see in South Africa. And this should enable disease centers overseas to collaborate with us, as it is unlikely that in a small country like South Africa with so many priorities vying for attention, that we would be able to fund and spearhead these research projects locally. So we will need some assistance from centers overseas. I thank you for your time and I look forward to your questions.
Thank you so much, Dr. Thomas, for all of that helpful information. This was really eye-opening, especially being a patient in South Africa myself. So thank you for everything that you've outlined there. I see we've got 2 participants who have their hand up. Now 3. This would be Manolo, Albert, and Claudia. I'm gonna ask, please, will you put your questions in the chat box? We are gonna take questions and allow our experts to answer those questions at the end of the session. But if you could just pop those questions, whether it be in the Q&A section of the meeting or even in the chat box, we'll get to those questions a little bit later. So next, I would like to hand over to Dr. Cynthia Wendo from Aga Khan Hospital, Aga Khan University Hospital in Nairobi, Kenya, please.
Good evening, everybody. Allow me to, yeah. Yeah, I hope my screen is visible to all the participants. I'm Dr.
Yes,
Matilda Wendo. Thank you very much. I'm Dr. Matilda Wendo, I'm a neurology fellow, currently based at Aga Khan University Hospital under the supervision of Professor Dilraj Soki. So I'm just going to give the NMO SD experience from East Africa, and I will look more on a few cases that we've actually handled and how we actually went about investigating and managing them. So historically, we know NMO has evolved over the years, all the way from DEVIC discovery to 2006, when aquaporin antibody positivity was included in the diagnostic criteria. And currently, in the 2015 criteria, we now know that we have aquaporin antibody positive NMO SD and aquaporin negative NMO SD. So Adilraj, Adil, Soraya, and Juza, who can Peter Mativo actually looked at cases of NMO spectrum disorders that presented to our tertiary teaching referral hospital. And this was published in 2021, although cases have actually changed over time. And they actually retrospectively looked at cases, and they were able to identify about 11 cases. They were able to identify about 11 cases. And out of these 11 cases, actually 10 were female patients, which is quite in keeping with epidemiologically known that females tend to get SMO more. In our setup, we do have aquaporin antibody testing. We are still doing the immunofluorescent testing, though the cell base is what is more standardized. So out of the 11 cases that they actually saw, about 7 were positive for aquaporin for antibody testing. And we are still using, for acute treatment, we do use intravenous methylprednisone, and there are certain cases of patients who do not respond well. We do plasmapheresis, and in this case, we had about 4 cases who required plasmapheresis. Out of the 11 patients who were seen, we had about 6 who were seen on first presentation by the neurologist. And this did change a lot in terms of outcomes. And here I'm talking about relapses that can occur. And for those patients who were seen at initial presentation, had fewer relapses other than those who probably hadn't had a first contact with a neurologist. The only outlier here is case 2, who had about 4 relapses, and this was because of loss to follow-up and was not quite consistent or compliant to treatment. The most common regimen we have is rituximab, especially for long-term therapy. And we also do put our patients on phenolate mofetil and azathioprine, depending on their desires to have children, especially for female who azathioprine would be more appropriate. So I'll go through some interesting cases that we've had. And case one, we had a patient who presented with persistent vomiting, and a week later had some subtle balance issues with weakness in hands and legs, was admitted under the gastroenterology team, and endoscopy done was actually normal. And on doing an MRI, had this hyperintense lesion that was both seen at the coronal and the sagittal view. The patient then received 5 days of IV steroids, methylprednisolone, then had oral taper over 2 months, and together with plasma exchange, had 5 sessions. We mostly do alternate days of plasma exchange. Then later on was commenced on rituximab with very good outcome and returned to work after about 3 months. Case 2, it's an interesting case, and it was an interesting kind of presentation. I'll play the video. So this is a patient who presented with dystonic spasms and also had quadriparesis, and on MRI scan had this expansile hyperintensity lesion at the cervical junction, both on the coronal and in the sagittal view. Had serum aquaporin done, which was actually positive, got IV steroids and plasmapheresis. The third case was a 30-year-old who presented with acute onset lower limb paralysis over about a period of 2 days. Initially had tested positive for herpes simplex virus 2, which was eventually treated. Presented to us later with vomiting, and on MRI of the spine had an extensive hyperintense lesion all the way to up to around C7. Was positive for serum aquaporin, and eventually was given intravenous steroids and plasmapheresis. This was quite interesting, and we actually also came across a paper of a patient who similarly presented in the same way, had post-herpes zoster infection, and eventually developed neuromyelitis optica spectrum disorders. The fourth case was an interesting case of a 30-year-old who presented with a history of bilateral ocular pain, and 4 days later developed bilateral visual loss, and on fundoscopy had severe papilledema. So the star images actually showed hyper-intense lesions bilaterally, but more on the right, and they were quite optic enhancement. She was, however, seronegative for aquaporins. Was started on intravenous methylprednisolone, however, did not respond quite well. Therefore, we proceeded to have plasma exchange and did very well with regain of vision. So currently, this is what we use, which is standardized, both to diagnose NMO diagnostic criteria in our patients in Kenya, both with aquaporin positive and aquaporin negative, or those who with unknown status. In terms of testing, yes, in our setup, we still use the immunofluorescent test, but as we know, live cell-based assay is what is currently recommended. We are currently testing it both in serum and CSF before treatment in acute stage, and also as we monitor over time as we are managing these patients. In terms of acute attack, in Kenya, our first line is high-dose intravenous methylprednisone. And for patients who do not respond or present with severe attack, then we do plasmapheresis. In terms of long-term therapy for patients who have aquaporin positive NMO, in Kenya, what is available for us is rituximab. The other therapies are not quite available and still quite costly for majority of our population. Our second choice is mainly azathioprine and mycophenolate mofetil, and this depends on the cost, given that rituximab is quite costly, and also in terms of family expansion, especially looking at the female gender who azathioprine will be more favorable. We do also have patients who present with double negative NMO, that is the negative for aquaporin, for antibodies equally, and also negative for MOG. It's quite a rare entity, but yes, we do see, and it's a syndrome rather than a disease entity. And we've had cohorts that have actually demonstrated that this cohort of patients do exist. In terms of if it's different between those who are double negative versus those who are have aquaporin positive, certain studies have actually tried to demonstrate the different pathobiological evidences. And this was a study that just tried to demonstrate CSF GFAP as an evidence. And actually patients who have aquaporin positive NMO tend to have very high CSF GFAP as compared to NMO spectrum disorder. So probably leading to the question, are the two different in terms of pathophysiological or histological data? Probably the data is still lacking even in our region in Kenya, and probably we may need to really delve more and see into that. For double negative NMO in Kenya, we still do give rituximab. We only treat a severe first attack or patients who present with a second attack, then we do treat, and we give rituximab, azathioprine, or mycophenolate. Tocilizumab is not quite available for NMO in our setup. So cost is still quite a challenge in Kenya. That those patients who probably can be covered with the National Hospital Insurance Fund, but still does not fully pay for rituximab infusion. And it was quite interesting that it's not only a problem that we are facing locally in Kenya or in Africa, because I came through this paper that was published by the French government that was actually looking at the cost of the monoclonal antibodies, and rituximab per patient annually per year was about 400 euros, and tocilizumab 10,000. And looking at the other treatment options like satralizumab, eculizumab, ravulizumab, it's quite expensive and quite out of reach for majority, not only in Kenya. So my take-home message is that yes, we do see NMO cases in Kenya. We still have diagnostic challenges, and cost is quite a big factor when we come to treatment. And for patients who have first encounter or are diagnosed early with the neurologist, then they tend to have fewer relapse with better outcome. And that's just my experience from the Kenyan population. Thank you.
Thank you so much for that information, Dr. Cynthia. I think it was super helpful that you've also included the different cases that you've come across. That was amazing and so interesting to see. Last but not least, we do have Dr. Mashina Chomba from Zambia who will be presenting for us tonight.
Thank you very much for the opportunity to speak to you today about our experience in Zambia. I just need to be able to share the slides. Dr. Wendo, if you could just unshare yours so I could share mine, then I'll get started. Okay. Thank you. How is that now? Are you able to see my slides?
We are able to see them. Thank you so much,
Great.
Dr. Chomba.
Thank you so much for this opportunity afforded to me by the Sumaira Foundation. And thank you indeed to the three speakers from the different countries that have spoken before me. I think they've made my presentation much easier because they've laid a very good foundation for the background of thinking about NMOSD in Africa. I only have one disclosure, is that most of the work I'll present today came out of work sponsored through the MSIF Dupree Award that I received in 2020 to 2021. And as stated already, NMOSD is still largely not very well understood in sub-Saharan Africa, but I find this interesting because in the global north or in most Western nations, NMOSD is considered more common in people of African descent, and yet little is known about its occurrence in sub-Saharan Africa. And I see this as an opportunity for clinicians, physicians, advocacy groups working in the region to try and add to this missing gap in global knowledge of the disease. So focusing on Zambia, where I practice at the University Teaching Hospital, for those who don't know where it is, it's the red country on the map on the right side. It's in, I like to think of it as South Central Africa, and it is a low-income country with a gross domestic product per capita of $1,000, 1,300 thereabout, which is considered as low-income country. And most of the health systems in Zambia have traditionally been built around HIV, tuberculosis, and malaria because these are highly prevalent in the country. Further to this, we have a very low doctor-to-patient ratio. We see about one doctor for 12,000 patients. And this number will probably change soon with the recent efforts to recruit and train more doctors in the country. But of note is that these doctors practice in tertiary or secondary hospitals, and the primary level healthcare is mostly catered to by clinical officers. We refer to them as clinical officers. In some countries, they may be referred to as physician assistants. And then there are some centers primarily managed by nurses only. So there's a huge gap between availability of doctors across the different levels of healthcare. The country now only has 7 MRI machines for a population of about 20 million people. And these MRI machines are not always functioning at the same time. We have lots of moments when one or two are not working due to the high load and high demand from these few machines we have across the country. And diagnostic tests are limited, and most of them are available in private sector and paid for by patients out of pocket. A lot of stockouts of medications are quite common, and priority is often given to drugs that treat HIV, tuberculosis, and malaria. So looking at NMOSD on this background, it's important to note that not until recently we had no neurologists training in the country. So there was no program training neurologists in Zambia, which I think is a big hindrance when it comes to diagnosis of NMOSD. But in 2018, with lots of collaboration across the world between Zambia and the US, we launched a training program at the University Teaching Hospital, and it trained Zambia's first ever neurologists Currently, we have up to 16 neurologists trained by this program. Of note and of interest was that only after setting up this program are we able to make our first diagnosis of NMOSD after we launched with this training program, as well as a neurology service at the University Teaching Hospital. So looking at that, we realized there might not be an absence of disease. There might be more an absence of neurologists and an absence of data. So we set out to form a registry of patients living with CNS demyelinating disease. And we launched the ZAM study in 2019. And to date, we have over 50 participants enrolled. And the distribution of these is almost even between NMOSD and MS. So we have over 25 participants with NMOSD, and predominantly over 90% of these are Black African individuals, and there is a higher percentage of these participants who are female than males, which is, as we've seen in other presentations today, and not really surprising from what we know about NMOSD. And this is a young group of people with an average age of about 36 years. So to try and break down the story we have in Zambia, it's very, very similar to what has been presented by my three colleagues from the region. But I think I'll try and illustrate it with a typical case of one patient, maybe share her story a little bit and see how it typifies the experience of most of our patients. So she came to us as a 40-year-old woman, and at the time she had bilateral vision loss, so she had difficulty seeing from both eyes. Her history began 3 years before she came to see us, and at that time she had difficulty walking. She had weakness in both her legs. And when she saw her doctor, she was told that she may have some non-specific transverse myelitis. Mostly, she was given a path that treated her for infection and then given oral steroids for almost 2 months. And she almost nearly made a full recovery. But a year later, she had a similar episode, but this time it was associated with urinary retention and constipation. So an MRI of the spine was ordered, and the report stated a mid-thoracic disc bulge with extensive intrinsic cord signal abnormality, which simply means that they thought one of the bones of the spine was pressing on the spinal cord, and it looked a bit swollen in the spinal cord. So they referred her to a neurosurgeon, who then did a discectomy to relieve what was thought to be the pressure on the spinal cord. She had some minimal recovery, so she was restarted on high-dose steroids for 3 more months. She regained some strength, but a month after that, she still developed this progressive paraplegia in both her legs, meaning both legs became weak. And so they ordered a repeat MRI, and it showed that the disc bulge was still present, meaning there was still pushing of the bones on the spinal cord. At least that's what the report stated. And so they thought this was a disc problem again, and so they treated this again and took her to theater. Her symptoms didn't seem to go away, and a week after this, she developed vision loss in both her eyes, so she couldn't see after the operation. They gave her some treatment, and then referred her to neurology, which was essentially a path that was started with referral to our hospital, then eventually to neurology. She reports that the way the visual loss happened was a cloudiness in her eyes, and then she woke up the following morning and couldn't see anything. So when we saw her at UTH, we took extra information, and she did endorse a feeling of this electric pain shooting down her spine and worsening of her symptoms when it's hot or when her body temperature is high, which we refer to as Lemaitre-Stein and Uthoff's phenomenon, which gave us a suspicion for a potential CNS demyelinating disease like MS or NMO. The rest of her history was unremarkable, and when we examined her, we didn't see anything other than problem with her eyes, in her pupil, and difficulty walking, and her limbs, her lower limbs, her legs were quite weak and spastic, and she was not able to walk. So at this point, we thought to ourselves there's a real chance that we could be seeing a patient who has either multiple sclerosis or neuromyelitis optica. And we ordered an MRI. At the time, as I mentioned, the MRI machine was not working at our hospital and it took a bit longer to get. So we asked her if she was able to pay out of pocket for a test, a blood test, and she got to do a serum aquaporin 4 antibody test at a private lab, and it was positive. And so we had our diagnosis of NMO in this patient, and so we treated her as such. But I would just like to take a step back and kind of give an illustration or a summary of her path to a diagnosis. And you note that the different colors on this diagram. I placed the green boxes in the column in the middle, which denotes the moments when she self-referred to see a doctor. So there was a lot of self-referral, self-advocacy. She had to keep going back to see different doctors, mostly in the private sector. And only once was she referred to see another doctor referred by a general practitioner in the public sector. That was an orthopedic surgeon and a neurosurgeon who did the spinal decompression. And despite her lack of response, the patient kept pushing and kept self-referring until she eventually got to UTH and got her diagnosis. So you can see we were close to the diagnosis with a non-specific transverse myelitis, not quite on the money, but she got some therapy that was close to what was going to help her. But beyond that, she got largely therapy that was not specific to the NMO that she had. We weren't able to see these disc diseases that were reported on the subsequent scans, but it was also difficult to comment since she had already had some surgeries for those. So this is her story, and I thought this was a good illustration of a typical experience, but it's largely what we see, and as we've seen from different presentations given today, there's a large delay in diagnosis and multiple steps and lots of self-advocacy is required before you get a diagnosis. So we have this as our diagnostic challenge. As seen from this case, there is limited awareness amongst health workers and the general public about NMOSD, limited MRI machines available, and aquaporin 4 antibody testing is largely not available. But I like to keep a glass half full attitude and call these opportunities. So maybe they're not just challenges, but opportunities for us to do some advocacy work on. So advocacy tailored towards policy change, looking at MRI distribution and greater availability of the tests. I think without evidence, it's difficult to advocate for these things. And some of the work we're doing and some of the patients we're working with are helping us push this agenda across the country. We're also hoping to leverage the very motivated new generation of young neurologists. I think this kind of work is very exciting for young neurologists, and we are a country that has only recently started training young people in neurology. And I think there's a huge opportunity in Zambia to create a workforce and a movement towards advocacy for NMO diagnostics and therapy. Speaking of therapies, we, like many presentations today, don't have the specific monoclonal biologic agents that are recommended for NMOSD, but acute attacks are treated with high-dose IV steroids, but these are bought out of pocket by patients. They cost about $170 depending on the exchange rate, and this is very much outside many of our patients' means at our hospital at UTH, at least. Plasma exchange is available only at referral hospitals, and its availability is not consistent either. Lots of challenges with reagents, and expertise is not often present in different hospitals across the country. Long-term therapy involves, more often than not, long-term, a long oral steroid taper orally. Azathioprine is one of the most common agents we have patients pay for that they can buy and take, but we do have a few patients taking rituximab as well a few months at a time. Supportive therapy is available with antibiotics where needed, supportive care for the bone health and vitamin supplements. Different drugs have different availabilities, but by and large, patients have to pay for these out of pocket, and when available, sometimes in the public pharmacy. Again, I like to see these as opportunities more than challenges, and we are working on including some of the therapies on the national insurance scheme and trying to see how that can be accessed by our patients. We have a national insurance scheme that it has a very modest contribution that patients can make every month, but be able to access medications. And if we can get these treatments on that scheme full time, then we might be one step closer to getting some treatments available to patients, as well as see how private pharmaceutical companies and the Ministry of Health and public sectors can work together to try and come up with MOUs or agreements for supply of these drugs to our patients. I'll end with a quick update on future directions. So lots of advocacy. Our patients have formed the MS Advocacy Group, which, like was presented by Dr. Duodu in Ghana, is mostly composed of MS patients, but we do have NMO patients on the group as well. I actually reached out to one of our NMO patients who's very, very happy to be more active, as well as to be part of foundations like the Sumaira Foundation and learn from any advocacy groups around the world. So patients are very motivated to try and build on this advocacy efforts. Neurology training and enrolling is ongoing, and we are now starting to see international students from the region, which might help create more awareness, not only in the country, but as well as the region. And we did have efforts to do regional training courses. Last year, we had the first virtual multiple sclerosis course that was targeted at ophthalmologists, neurologists, and surgeons across Africa, and were able to reach up to 1,200 participants over 5 days. And this was across 15 countries in Africa. And I think this was a very good first step and a model for us to try and raise awareness across not just regions of Zambia, but across Africa. And I think more focused courses on NMO would be the next obvious step using this model. So we also did launch the Afric TRIMS, which is an African Committee for Research and Treatment in MS, but we also have research supported through this Afric TRIMS on NMO as well as MOGAD within Africa. And I think many of us on the call might be members. If not, I urge everyone to join Afric TRIMS. I also do echo Dr. Thomas's sentiments about collaborations across the different countries, getting our data into one place and see what we can learn about the epidemiology, support clinical trials, patient advocacy, as well as just centers of excellence across the region. And I think Afric TRIMS is a good place to start. I also want to acknowledge the efforts of the Africa Oxford Initiative and the Sumaira Foundation, who trained our lab technician, Caroline Kawe, to get training on performing cell-based assays for MOGAD, as well as aquaporin 4, which is a huge step in improving the capacity for diagnostics in the region. Ongoing research is key for these efforts, and I would like to acknowledge my colleagues in this effort, our mentor, Diana Saylor, and my colleagues in research, Sarah Brown, Maria Sahu, Frighton Mutete, and Dixon Munkombwe. And there's a lot of motivation within this group to potentially get to a point where we do clinical trials in the region. I also like to acknowledge our patients who are always ready to support any advocacy efforts and who are always available for any of our research efforts. I would also like to give special recognition to the Sumaira Foundation, who are always reaching out to us, checking in on us in Zambia and the region, as well as organizing this wonderful seminar and webinar, and hopefully we get more of these in the future. Our other supporting partners, our team as a whole across the nation, Fiifi, Dilraj, Alexander Simpson, and many of our colleagues that we've worked with over the years. And I'll leave you with this picture, which I hope paints a more hopeful tone to many of these challenges that we're facing. And I look forward to your questions. Thank you very much.
That was incredible. While Letitia starts to gather the questions, because there are plenty, I would love to call on, we have someone in the audience, not just someone, Dr. Sara Mariotto. She's tuning in here from Italy. And I guess one of her slides were cited in the Dr. Wendo's presentation. Sara, did you want to say something?
Yeah, of course. So I everyone. It's a great pleasure for me to be here, and I really love the presentation. And I think that it's great, Sumaira, that you organize such webinars. It's very informative, and I think very important, because whenever we write something and design something, we have to take into account the whole world of situation of the whole world. And I think that Africa is very much important for everyone, and should be taken into account for whatever we are saying and organizing. And of course, I don't know what I could do, but I'm very happy to support every kind of initiative you have in mind related to diagnostics, which is my field of main interest. But to everyone, I'm really happy to support whatever. I mean, I'm really glad of listening to this presentation and all this organization. And I would really love to be more involved on this, because it's very much important for everyone.
Great. Thank you. Okay, Letitia, fire off.
Sure. Thanks, Sumaira. This has been amazing. I'm so happy to actually see the amount of questions that we have. So first up, we've got a question from Errol Kruger, and he wants to know if there are any of the panelists familiar with epidural spinal stimulation and stem cell therapy for treatment of paraplegia due to NMO.
Think maybe if I can just afford an answer. I think in South Africa, we do have quite a number of sort of non-evidence-based therapies available. You know, as far as I know that, you know, this is not an evidence-based intervention. So I think it is important that one should have a discussion with your neurologist about the therapies and the underlying evidence base supporting it. You know, within the healthcare sector, there is unfortunately a market as well, so that there are people with, you know, incentives, you know, pecuniary incentives, not necessarily the patient's best interest at heart. So I would recommend in our setting that someone has a discussion with their doctor. And, you know, from listening to the other panelists talking, it's apparent to me that, you know, even making such a statement is not a reality in most of sub-Saharan Africa because of the limited access to doctors with specialist expertise. And, you know, because of significant diagnostic delays, etc. So, yeah, it's been quite an eye-opener for myself as well.
Yeah, if I may just add to Dr. Thomas's comment about the timing of it, I think the epidural spinal stimulation has mostly been shown to be effective in spinal cord injuries, and I think there's a bit of a time sensitivity to the therapy, but given our diagnostic delays and difficulty accessing specialist care, as Dr. Thomas has said, I think we're a way off, at least in Zambia and most countries, before we are able to answer that question, at least here in Africa.
Sure. Thank you so much, Dr. Thomas and Dr. Chomba, for those answers. We have another question. I'm assuming, because of the nature of the question, I'm assuming this is directed to the South African area, but the question says, it's from an anonymous attendee. Has anyone had success with the Council of Medical scheme when the private insurers refuse to cover rituximab after previously covering plasma and rituximab?
So I have worked in the private sector in South Africa, and for the most part, if a patient is seropositive, NMOSD, meaning they are aquaporin 4 antibody positive, it is usually not a hurdle in accessing disease-modifying therapies, provided that the clinician has followed the state protocol of care. So unfortunately, within the state sector, we still traverse a staircase where we start with a platform therapy. And if you fail that, azathioprine, you are offered mycophenolate. And if you fail that, then as a final last-ditch stand, we offer rituximab. And that is because, because of the cost of rituximab, we are also not able to offer it universally as a first-line therapy. Now, there is an added complication that in South Africa, we also have different grades of medical aid available, so that some medical schemes behave like medical insurance, and some behave like medical aid schemes, meaning that they universally cover the state basket of care. So it's a bit difficult for patients when they purchase their healthcare in South Africa, because they may not be clearly informed of what they have purchased. And this information then only becomes, comes available or too late, in a post hoc fashion after the patient has manifested with an illness. So, in this particular case, it might be related to the fact that it was not the state protocol of care that was followed, or that the patient has a medical aid that is not indeed, a medical aid as regulated by the Medical Schemes Act, but a form of medical insurance, which is a lot more limited in the benefits it offers.
Sure, thank you very much, Dr. Thomas. In terms of Rosalind's question, we've got Rosalind, one of our ambassadors, who would like to ask Dr. Wendo. Well, she's just saying thank you very much for the presentation, and that she was diagnosed and treated at the Aga Khan Hospital, and that your work is greatly appreciated. She would like to know, out of curiosity, what is the average age range of presenting patients in Nairobi?
Thank you very much, Rosalind, for the question. So from the cases that we actually presented and published, the average range age is about 30 years, but we've seen patients as young as 12 years and as old as 45 years. And currently, now that we are now diagnosing NMO more, probably the landscape may actually change, and we might even see more wide age reference. Thank you.
Thank you very much, Dr. Wendo. We've got another question from Dr. Sarah Mariotto, and she would like to know if there are any sites in Africa offering live cell-based assay for MOGAD and NMOSD.
Yeah, so I can speak for that in Ghana. I think in Ghana, most of the labs actually do the ELISA type, but there is one particular lab that does the live cell-based assay. Actually, it's a lab from India called Metropolis. So they tend to do, but so it's for them, it's quite expensive because they are doing this the cell-based assay compared to the ELISA. So when you write the request for them, the patient unfortunately might end up going for the cheaper one, which is the ELISA, and which is not quite specific. So we have the cell base, but it comes at a cost about close to about $140. And it's a combination. So the one you ask for it, they say they do both the NMO and then the MOG together.
If I may respond for South Africa, so universally we use a fixed cell-based assay. We use the Euroimmune kit, but we do have the infrastructure, obviously, to advance to the live cell-based assay. And I think at this point in time, the only reason why we have not done that is probably because it, in our setting, is still a rare disease. So within the NHLS, which is the government-funded National Health Laboratory System, they unfortunately also have to prioritize their technology and infrastructure to our health priorities, so that, you know, we have, for instance, the most, you know, recent advances in gene expert technology for the diagnosis or rapid diagnosis of tuberculosis, multiplex PCR, but, you know, we don't have access to live cell-based assay. Thank you.
Thank you very much, Dr. Thomas and Dr. Duodu. We have another question also from one of our ambassadors, which is from Lois King. And she's saying, for Dr. Duodu, great presentation. Very few patients have been identified. So there's definitely a need for more data. But are you aware of a difference in prevalence between urban and rural dwellers?
Yes, I must say, so the registry, I must say, is purely data gotten from my teaching hospital, and it's urban population. And so we have people feeding from the urban population. We are not yet in the rural because the registry is still growing. But I must say that we have one, to my surprise, there was a patient I once saw from this. We have a school of the blind where, so this patient actually became blind, I think at the age of a teenage years or so, and was pushed there. She relapsed and had transmyelitis and came back this time. So then we actually screened for NMO and was positive. So you're right. I think there are a lot of rural areas where these people are neglected. Of course, for obvious reasons, there are not much neurologists in our part of the world. Though we are growing, we have about close to 15, still growing neurologists. I think how to tackle this is what we did, like Dr. Mashina said, to actually do a lot of educational sessions with general physicians, because this patient first attend to the general physicians and sometimes ophthalmologists, which we did with the MS educational course in May last year. So we hope that as these things goes on, we might be able to capture a lot of these people who are in the rural areas as time goes on.
Thank you for that answer, Dr. Duodu. We've got a question for Dr. Chomba, and Sungaweni Kangwa would like to know, would it be beneficial for the Zambian register to get more patients added, even if we are non-residents?
Thank you for the question, Sungaweni, and I think you are very much welcome to be part of the efforts and the team that we have here in Zambia. If it's possible, I can share ways in which you can reach me, and we'll definitely be able to include you. I think from the chat, I was able to see you are in the US, but originally from Zambia. So we will definitely be able to reach out and see if we can be, you can be part of the, not only the patients team, but also any advocacy work that we're doing in the region. Thank you for reaching out and letting us know. It's really helpful.
Sure. Thank you so much for that answer, Dr. Chomba. We've got a question from Deanna Saylor, and I'm assuming that she's directing this question to all of our experts in general, but she's asking, how representative do you think your registry and patient data are? In other words, are the patients you see skewed in some way compared to the general population? How can we reach populations who are less represented?
And I'll just say Dr. Saylor is actually with us here, so I've promoted her to be able to talk. So Dr. Saylor, if you want to join the conversation, but of course your question is directed to these panelists.
Sure, I'll just briefly say, really, really happy to just hear the conversation and that this has been elevated to the level of people being aware that this is a problem in sub-Saharan Africa. Really grateful to all the speakers. Y'all did a great job, and really grateful to you, Sumaira, for putting on the webinar. Curious to hear everyone's thoughts.
Who wants to go first?
Oh, yeah, I'll say from what I said initially, I think a similar question. So from our registry in Ghana, I think it's not really representative of the general population. It's mainly urban based, and for obvious reasons, where for those who have access to neurological services, it's in our parts, It's mainly those in the urban areas who have access to neurological services. Not only that, it's a cash and carry system. So look, if you do not have the money, you could see from the data that it took people even 11 months when the first symptom before they were able to do an MRI. So these are some of the challenges that comes with it. Of course, so the financial bit is very, very crucial. Even the investigations, I have patients, they go and you have to keep calling them and they'll tell you, unfortunately, they do not have money and they have money for maybe their acute treatments. They take their IV methylprednisolone, pay huge sums of money for the drug, then they can't continue the investigative process. So the next moment you see them is another relapse, and you just have to use your clinical as well as, even you do not even have a radiological characteristics to even classify what you are dealing with. So it's not really representative. I think maybe a population-based study would be quite helpful if we, I mean, of course, this needs to do with funding, where we can actually go into the rural areas and actually try and also have give them this kind of access. Another barrier to be taken care to be removed in this part is really finances. If most sub-Saharan and even in Ghana, be it the investigative processes, the management itself is really taken care of by our health insurance, that would be relieved. That would take a lot of burden from our patients, and then we can actually see what is going on. I believe there are a lot of patients out there, like I clearly said, there's people who get blind and they're just sent to the school of the blind. I'm sure when we go there, just do a study there, you'll be surprised those who are NMO or even MS, because I have one patient coming from that place.
Yeah, if I may just add to Dr. Duodu's comment, I completely agree. Just for everyone to know, I know Dr. Saylor knows this, but I work primarily in an urban hospital, but recently I've had an opportunity to go to rural parts of Zambia. And not only is there a lot of neurology in Zambia that is largely catered for, but there's also a lot of paraplegia. There's a lot of different syndromes that present with paralysis, as Dr. Duodu mentioned, blindness. And I think these registries, as we've seen from the different cases, primarily consist of individuals with high education, with a lot more means to push through the misdiagnosis and get to self-advocate until they get a diagnosis done. And I think I'll speak for Zambia and maybe even Ghana. They probably just cover the tip of the iceberg and just a very small portion of the true picture. And I think most of the efforts that as AfricTrims, as well as the different efforts in the different countries to try and train even the non-neurology healthcare workers. It takes more time to train a neurologist, but it might be quicker to also raise awareness amongst non-neurology doctors who are in the primary care for many patients, even in the rural areas.
If I may just respond for South Africa. So I think in our setting, what we need to do is have a more centralized database, because we have different institutions, whether these are academic or private institutions, where these patients are actively managed. It is true that these centers are skewed towards the urban centers, but we do have the backbone of excellent sort of cellular network. We have quite a lot of road infrastructure, so that telemedicine and outreach activities are absolutely possible. But it is, the act of being able to collate the data, to be able to collaborate across centers, and to be able to be accessible to colleagues in the periphery when they have a patient. So in our setting, it unfortunately does not bode well for a patient if they are living in a rural area and they become symptomatic, but that usually means that there's a delay in access to care, not as, unfortunately it appears that means that there's a non-diagnosis, as in other African countries, which is very concerning. And I mean that I believe that is a human sacrilege that still happens for an imminently treatable disorder. Thank you.
Thank you, Dr. Thomas, for sharing that insight. We've only got time for one more question, and I would like to direct Dr. Paul Bolge's question to the panelists. So he says, fantastic presentation to everyone. Do we have data to capture the outcome in terms of functional recovery of this patient? How much MDT-based neurological and spinal rehabilitation do these patients get, which is crucial to reduce impairments, reduce activity limitation, and improve participation using the HWOICF?
If I may respond. So within the South African setting, although we do not formally have rehabilitation specialists in our country, there are several doctors who make a career of rehabilitation medicine. So we have several institutions, both on the state and private sectors, where patients are able to be admitted, after they have had the acute presentation and interim management under a neurology service for long-term rehabilitation. And they have access to the wide scope of services, including physiotherapists, occupational therapists, orthotists, and many of the medical doctors who make a career of rehabilitation medicine are also trained in using botulinum toxin to manage spasticity. So we do have a very well-resourced setting, but access is often a problem, simply because there are a very large number of patients, unfortunately, that we see with stroke. So that predominantly those services are saturated with stroke patients. And patients often have to wait in the hospital setting before they can be admitted to a rehabilitation setting. I would love to hear what the status quo is in the rest of Africa. Thanks.
Yes, for Ghana, I'll say that it is well structured when it comes to stroke, because we have a well structured MDT with almost everybody, including clinical psychologists, occupational therapists, like you said, physiotherapists, and even dietitians, where everybody is on board when it comes to these things. And sometimes there's a follow-up plan in the stroke when they go to their home. But when it comes to the demyelinating diseases, I think it is relatively new. The service is a little bit disjointed. They receive their services as on referral basis. So a doctor sees things, you need a foot or toes, you need to see an occupational therapist, refers to occupational therapist, and there's no sort of communication, more or less. What we plan to do is to really borrow what the stroke unit does in our part of the world, in Ghana, to see whether we can help these our patients, because frankly speaking, from our cohort, there are not that many, and we can actually bring them together. I actually have on my WhatsApp page, some of the patients actually does these orthosis, and so sort of those who have the foot drop in MS and things, he sort of give them assistance at their orthosis joints, but we do not have it standard or an MDT for our demyelinating disease like NMO and the MS.
Yeah, if I may just echo the situation in Ghana, it's quite similar to ours in Zambia. We don't really have dedicated rehabilitation for NMO or demyelinating diseases. And I think we are, given that we have only recent efforts for identifying neurological diseases in general, as well as NMOSD, this is an area which could benefit from raising awareness, even in healthcare specialists outside neurology, to set up those deliberate systems for rehabilitation. So MDT is extremely important for recovery.
Oh, maybe I can just give the Kenyan perspective, more so Aga Khan. We do have an MDT approach where we do have physiotherapy and occupational therapy. I've just had from South Africa about Botox. And for us, Botox, we mainly use for patients with stroke or spastic hemiparesis, but not so much for NMO, but probably something that we may need to look into that. Thank you.
Well, that's all the time that we have today, and we're over by 15 minutes, which means we could have talked about this for longer and longer and longer, which tells me we need to do this more often. First of all, thank you all so much for taking the time out of your very busy schedules to be with us today. Dr. Duodu, Dr. Chomba, Dr. Thomas, Dr. Wendo, we know how you're seeing patients, you're doing research, you have your own families, and you took so much time out of your day to be with us today. So thank you very, very much. Thank you, Letitia, our ambassador of South Africa and International Ambassador Liaison, for moderating this webinar. Thank you to all of the guests today who are here live. We've been doing webinars now for 5 years, very regularly all over the world. And I have never seen so many people register for one of our webinars before. So I think that tells me and all of us that this is a very important conversation, and that we need to keep talking, but more than talking, we need to do some action to help the situation in all parts of the world, namely here, sub-Saharan Africa. So thank you all very, very much. This webinar is recorded, so we're going to post it everywhere. So in case you missed it or you want to reference it, you can most definitely go back to it. But just a huge thank you from me and the foundation, and happy NMO Awareness Month. Thank you to the doctors for being here.
Thank you for having me. Thank you,
Thank you for
everyone.
having me as well. Thank you so much. That was quite informative, guys. Thank you.
Thank you very much.
My pleasure.
Thank you. Thank you very much. It was informative and very eye-opening.
Yes, and I hope our paths meet in person very soon. We will find a way. Have a great night, everyone, and happy NMO Awareness Month. Bye.
Good night.
Bye, everyone.
Bye-bye.